my name is Justin Ritter, and today my project goes over the monoamine theory of mood disorder and specifically how it relates to depression. So, according to the DSM 5, depression is characterized by having 5 or more of the following symptoms within a 2-week period. And at least one of these symptoms has to be a depressed mood for all or most of the days, and or a diminished pleasure in normal activities. Other symptoms include weight loss, trouble sleeping, or trouble falling asleep, psychomotor agitation, fatigue or loss of energy, feelings of worthlessness or inappropriate guilt, a diminished ability to concentrate or indecisiveness, and or recurring thoughts of death, suicidal ideation, which may or may not include actual suicide attempts. So the risk factors of depression, there are environmental factors like negative childhood experiences, social determinants, and or stressful life events. And there's also a genetic component, with those whose parents had major depressive disorder being 2 to 4 times more likely to develop it as they grow up. Women also experience the development of major depressive disorder relative to their reproductive changes. Other course modifiers include basically every other non-mood disorder, anorexia, OCD, and these substantially increase the risk of developing major depressive disorder. So the monoamine theory of mood. This theory posits that mental disorders are caused by the absence of certain neurotransmitters. They're called biogenic amines, or the incorrect transmission thereof. So this theory actually built upon the basic emotional theory, which states that we only have a few predefined emotions as humans, and these are considered base emotions, and all of our more complex feelings are just combinations of these emotions and different severities. So this theory essentially states that mood is modulated by noradrenaline, dopamine, and serotonin, and the absence of these neurotransmitters in their normal amounts is actually what causes mood disorders. So, the general function of these monoamines. Dopamine is responsible for the reward functions of the brain, like feelings of joy and happiness, and these are important modulators also in the autonomic nervous system and for regulating hormone release. A lot of party drugs affect dopaminergic systems. Noradrenaline, also known as norepinephrine, so Na or Ne, are responsible for processing working memory and for behavior and attention regulation. They're also responsible for arousal, not necessarily just sexual arousal, but that's also included, and a person's overall vigilance, think fight or flight. Serotonin, also known as 5-HT because it is a modified amino acid, modulates sleep and memory and inhibits compulsive thoughts, and that's a big one for depression. So, let's look at monoamines in the brain. So these are released by the neurons via calcium-mediated exocytosis. So essentially, they form within a vesicle, and which is just like a small membraned-off portion within a cell. And when it gets to the actual cell membrane, it releases all of the monoamines into the synapse, so the area between two neurons. So they will interact with receptors on both the presynaptic and postsynaptic cells. So both the one that released it and the one that is, receiving the neurotransmitters. And these are primarily reuptaken by the presynaptic cell, but they can also be uptaken by surrounding glial cells and by enzymes in the intracellular space. So the primary enzyme right here, this big old blob right here, is a flavin-dependent enzyme known as monoamine oxidase. And this is found on the outer membrane of mitochondria, and it is the primary enzyme that kind of metabolizes all biogenic amines, not limited to just dopamine, norepinephrine, and serotonin. And this general process works by oxidizing this amine group right here. It normally has a higher affinity for the uncharged group. It is shown to be charged right here. But what it does is it transforms this amine into an imide, which is just a nitrogen double bond, and then into the aldehyde. So the monoamine theory of depression is essentially that the synapses in the brain do not have enough of these monoamines, and this can be caused by an overactivity of MAO, or the decreased function of transporters that actually get the neurotransmitter out into the synapse, or just a decrease in the number of or function of the specific receptors on the cell. And notably, this does not actually include a lot of the environmental or cofactors in depression outlined in the DSM. However, this is one of our best theories as to what causes depression. So, the treatment of depression with antidepressants. So, historically, the first discovered antidepressant was apromazine. Yes. It was actually discovered in 1952 when researchers were looking at antimycobacterial compounds. But this one was found to have some significant psychoactive effects. And it was found that these psychoactive effects occurred because it inhibited the enzyme monoamine oxidase, which allowed for higher concentrations of the important neurotransmitters to still be in the synapse. Tricyclic antidepressants were discovered a little bit later and were found by modifying phenothiazines. And these just reduce the reuptake of norepinephrine and serotonin from the synapse. It doesn't affect its metabolism, it just keeps it from leaving so they can actually, bind to receptors more often. So these were actually found, the tricyclic antidepressants and the MAOIs were actually found to have a lot of toxic side effects. So people wanted to develop new antidepressants, and it led to the creation of the selective serotonin reuptake inhibitors and the serotonin and norepinephrine reuptake inhibitors. And there was kind of a schism between whether people thought that primarily serotonin or primarily norepinephrine caused depression, and while they obviously both play a role, it led to people developing SSRIs and SNRIs, which SSRIs are specific to serotonin, while SNRIs are both serotonin and norepinephrine. And there's also other classes of antidepressants, but they aren't as commonly prescribed. So, monoamine oxidase inhibitors. These are primarily used to inhibit metabolism of neurotransmitters. They're used as antidepressants, but they also have roles in Parkinson's as an anti-Parkinson's drugs. But these aren't selective, and MAO is responsible for the degradation of a lot of biological amines. So you see a lot of side effects, including a lot of GI side effects, considering that there's a lot of neurons in the gut, the enteric nervous system. So these drugs include, as you can see, the following. But this selagline is actually interesting. So MSAM is a dermal patch, and it's actually been shown to have a lot fewer side effects than the other ones that are taken orally. So into the tricyclic antidepressants, these work by inhibiting the reuptake of norepinephrine and serotonin back into the neurons. So this increases the overall concentration of these two in the brain and body. So these are first generation antidepressants. They were developed after the original MAOI, but they're still considered first generation, and they have a lot of side effects. Specifically, tachycardia. You don't want an antidepressant to be affecting your heart that much. So these aren't typically prescribed very often specifically for depressants, but I do know that they are prescribed very often for off-label things like anxiety, or if an antidepressant does not work, as well as you would want it to. So getting into the more effective medications, you have the serotonin and norepinephrine reuptake inhibitors. So these function similar to the tricyclic antidepressants, not depressants, antidepressants. And they just work by inhibiting the reuptake of norepinephrine and serotonin back into the neuron. And these are preferred because they have less of an effect. So they have less of a side effect on the body. So while you're not going to get specifically tachycardia, you might see, a slight increase in blood pressure and heart rate, but it's not as serious. But you also see they do still have some of the similar side effects as the tricyclic antidepressants did. So dry mouth, nausea, vomiting, dizziness, fatigue, and also sexual dysfunction. And as I outlined previously, norepinephrine and the other monoamines do have a role in the, kind of sexual arousal and sexual behavior. Finally, the most common class of antidepressants. the selective serotonin reuptake inhibitors. So these differ from the SNRIs in that they are specific only to serotonin. They don't mess with norepinephrine and they don't mess with dopamine. So they're the most commonly prescribed antidepressant, but there is research to suggest that SNRIs are more effective. But this isn't conclusive research, as can be seen by the fact that these are the most prescribed. So these have basically the same side effects as the SNRIs. However, it is notable that anxiety is a bigger side effect with these, which is bizarre because this is also a drug that's used to treat anxiety disorders. As you can see by the Tony Soprano example, in the show, he was prescribed Prozac to help with his anxiety after he had an anxiety attack, and this is consistent with FDA regulations on prescribing the drug. So there is one thing I wanted to mention, and this is specific to the SSRIs in general, but serotonin syndrome is just caused by the extreme excess of serotonin in the body and brain, and this is associated with any drug that messes with serotonergic systems. So basically every single antidepressant, as well as some herbal remedies like St. John's wort. And this causes some mild symptoms, basically the side effects you see above, but also severe tachycardia and, shaking. And this is mostly caused by taking 2 or more antidepressants at the same time, or taking something that messes with the serotonin system. Or sometimes you have people who take 2 separate doses of a single antidepressant because they need a higher dose, or they just accidentally take one once they're increased or decreased in dose by a doctor, and that can potentially cause serotonin syndrome. So that was my presentation. Here are the references I had, and thank you for watching.